For the third segment, we'll talk about the other two manifestations of racism, internalized racism and interpersonal or personally mediated racism as part of Jones's typology. And by way of definition, we can think of internalized racism, courtesy of Jones, as the subjective acceptance of a dominant group's attitudes toward a subordinate race as inferior. And she describes internalized racism as manifesting in a number of ways, including the valuing of whiteness, for example, through appearance and the use of things like skin lighteners, also through devaluation, which might include using or endorsing racial slurs, and also generalized feelings and behaviors reflecting resignation and helplessness, particularly in the face of racial adversity. Internalized racism is the type of the three that is least studied with respect to health outcomes. There are some exceptions, and some studies have looked at measures of trying to approximate internalized racism and found that they're related to things like psychological distress, alcohol abuse, etc. One interesting study that I'll highlight is one by Che and colleagues in 2010, which is included in your recommended reading list, where they looked at measures that have tried to approximate internalized racism as effect modifiers of the discrimination, the Racial Discrimination Health Association. Specifically, the way they tried to capture individuals' internalized negative racial group attitudes or internalized racism was through a measure that asked for endorsement of 3 items assessing agreement with negative statements such as reflecting negative stereotypes. Blacks are lazy, blacks give up easily, blacks are violent. So individuals were scored on their level of endorsement with their agreement with these items and aggregated to produce a score ranging from 3 to 12, where higher scores represented more internalized negative racial group attitudes. There are a lot of limitations with this study, and one of them is, you could argue, the way in which they've tried to operationalize the construct of internalized racism. So you might say that this is an inadequate measure, which is a legitimate concern, but given the data availability, this is what they were able to do to try to approximate it. What they found was an overall score in this index ranging from 3 to 12 of about 6.5, with 35% of individuals indicating overall agreement with negative beliefs about blacks. I should have specified that the individuals here are black themselves. And the high levels of agreement corresponded to a total score of 8 or higher. And then what they did is looked at the interaction in the following way, which is rather tricky to interpret. I encourage you to read the paper if you're interested. Here they're looking at the predicted probability of a history of cardiovascular disease. So this is not a prospective study, which is another limitation to it, against self-reported experiences of racial discrimination in none, 1, 2, or 3 or more situations. And then the interaction here is represented by the stratification of the groups into high internalized racism or low internalized racism, again operationalized as a high score on this index of negative racial group attitudes versus low score on the index of negative racial group attitudes. And what they find suggests something's going on here, but again, what exactly is going on here is kind of open to interpretation. A couple of different ways you could look at this. For example, in the group reporting no experiences of racial discrimination, no situations where they encountered interpersonal racial discrimination, those who had high levels of internalized racism, according to this measure, reported much greater risk of cardiovascular disease relative to those who had low internalized racism. And this might suggest that the folks that this category is problematic in itself and could reflect some kind of internalized process of denial. And it's those individuals who have high negative racial attitudes or internalized racism who are most likely to report fewer instances of discrimination, but nevertheless manifest as higher risk of the cardiovascular outcome. The other way in looking at this is what the trends look like across the degrees of racial discrimination. So for those groups, for those individuals in the low internalized racism group, you have a pattern here that might be more or less as expected, where you have a higher risk of cardiovascular outcomes with more situations of racial discrimination encountered. That would more or less be what would be expected. What's interesting here, though, is that among those with high levels of internalized racism, you have the inverse pattern going on here, where those reporting no racial discrimination are at highest risk relative to those reporting less. And of course, these two categories here at the end are both inconsistent with the patterns for each group. Here it's going down with higher levels of discrimination and then a little uptick. And here for the low internalized racism group, it goes up with more experiences of discrimination with a slight downtick. This could just be noise in the data or perhaps more meaningful. The takeaway message here is that there is something about the reporting of racial group attitudes that might be modifying the effect of reporting discrimination on cardiovascular outcomes. And this may reflect the fact that a different willingness to report experiences of discrimination, recognize them as such, and report them among people who have high or low levels of internalized racism. And that what's most unhealthy is to experience high levels of discrimination but not report them. And that might be related in some way to the degree of internalization of negative racial attitudes. Another construct that is closely related to but very much distinct from internalized racism is Claude Steele's notion of stereotype threat. Stereotype threat is the threat that is a threat related to racial bias that is situational and induced interference with one's sort of self-concept. Specifically, it's the threat of being viewed, that people experience, through the lens of a negative stereotype, or the fear of doing something that would inadvertently confirm that stereotype. And Claude Steele is a social psychologist who's done a lot of really interesting experimental work among mostly Stanford undergrads to document the pernicious effects of stereotype threat that operate on all different kinds of racial, ethnic, minority, gender minority groups, and how what happens in these studies is that through the experimental design, if the threat of being identified with the stereotype is activated merely through some manipulation whereby the stereotype is primed prior to the subjects being asked to perform a test of some kind, for example, the priming with the stereotype is much more likely to activate it and then produce worse results, worse performance on a given task. So if you ask people to perform a math test and you prime the subjects in the experimental arm with a stereotype that women do poorly on math tests or usually don't have high aptitude in this particular domain or whatnot, then the fear of reinforcing the stereotype will actually induce poor behavior relative to the same group randomly assigned to the control condition that does not experience the priming of the stereotype before being asked to perform the task. What Steele and others' work demonstrates is that this is an environmentally induced performance impairment, and the reason why it's related to but distinct from internalized racism is that this process works in the absence of any pre-existing sense of group inferiority. That simply by being exposed to, primed through this situational event or cue, then this process is activated and can induce poor performance. And the effects that these studies document is hypervigilance among participants who are primed with these cues, also disidentification or withdrawal from the threatening domain, which is particularly likely if one is strongly invested in the given testing activity, of the particular testing activity being used. And so if we extrapolate from these experimental studies to the real-world situations, one can imagine that the bombardment of cues and stereotypes in social situations might induce negative outcomes, first of all, and second of all, over time, create these kind of secondary effects of hypervigilance, hyper sensitivity, around the threat of being stereotyped, and then ultimately over time the disidentification with a domain that might be perceived as being risky or threatening because of the probability of, or the concern about reinforcing a stereotype by attempting to engage in it. Steele and others do offer suggestions for remediation, which is somewhat encouraging. Mostly they're looking at outcomes in educational settings, but of course the impact of this kind of process could be across the board and also affect health outcomes. And the remediation just consists of things like modifying the structures, the structural environment, addressing attributional ambiguity, which is often where stereotype threat is more likely to occur. It's not likely to occur if it's very, very clear what performance is related to versus where there's some ambiguity. Is there bias going on here? Is there stereotype going on here? That is much more likely to lead to negative attributions if there is ambiguity. And also just different kinds of social interventions which might restore social trust and make individuals feel like they are at less risk of reinforcing negative stereotypes. And some of that may just be a function of the sociodemographic diversity and composition of a particular arena in terms of how much people are more likely to feel like outsiders to a given domain and be concerned about this type of process happening. Okay, moving on to the third type of racism or discrimination, that which is interpersonal or personally mediated. There are several domains of interpersonal discrimination that are relevant and can be studied with respect to their impact on health in ways that correspond very closely to what we talked about before with respect to stressors. And in this way, discrimination, interpersonal discrimination, is primarily conceived of as an important social stressor. One important distinction between structural discrimination and interpersonal discrimination is that when we look at what's on the pathway between structural discrimination exposures and health outcomes, we're primarily thinking in terms of material resources, because structural discrimination impacts people's labor market outcomes, educational attainment, earning potential, and so forth. It's primarily a material pathway or mechanism by which structural discrimination is hypothesized to affect health. When we're talking about interpersonal discrimination, it's much more in the domain of a social stressor, as something that is perceived by individuals and experienced as a social stressor with consequential impacts on health. So again, it can be conceived of something that's a daily hassle, an acute life event type of situational, losing a job, etc. It also can be chronic in nature, but whether it's acute or of the more quotidian, day-to-day kind of hassle domain. The relevant dimensions when conceptualizing interpersonal discrimination are both exposure and the response coping, which we saw before when talking about stressors more broadly, as two important dimensions of understanding the effect of stressors on health. There's whether you get exposed to it, and then there's how you respond to it or react to it. The third in here that's a little bit more relevant for stressors involving bias or discrimination is the appraisal piece or the attribution. So here there is a third dimension, which is about the sense making of an experience of interpersonal discrimination. So when you experience a negative interaction, for example, is there attribution to a process of bias or discrimination, or a different kind of attribution, which could be my counterpart is in a bad mood, or I am deficient in some way, etc. There's a multitude of ways of appraising a given situation that may involve discrimination as an attribution, an interpretation of that exchange, or other processes. So that's an important dimension, and there may be important inter-individual variability in the likelihood of appraising a given interaction or experience as one involving discrimination or bias in some way. And then a third component of trying to study interpersonal discrimination, and this is the most studied dimension of discrimination with respect to health outcomes, is how it's measured. And some studies historically, less so now, have relied on phenotype as a way of approximating the risk of exposure to discrimination. So really using it as a proxy rather than measuring experiences of discrimination directly. But in some ways, these studies have some advantages and unique characteristics we'll come back to. More common is the self-reported perceived discrimination type of measures, and there are 3 examples here. The Schedule of Racist Events, Williams' measure of everyday and major discrimination, and Krieger's measure of experiences of discrimination. And we'll be going through some of the details of these measures in a little bit. In terms of research, again, this is the most studied dimension of discrimination with respect to health. Population-based studies are typically reliant on subjective perceptions of experiences of discrimination and therefore are self-report. There are some examples of experimental studies in psych, primarily, like stereotype threat. In addition to stereotype threat, other manipulations in an experimental setting where people are in the experimental condition are primed to believe that they are in the receiving end of some kind of discriminatory exchange or experience, and then with assessment on different kinds of psychological and physiological outcomes associated with that. And again, the pathway that we're working with primarily here is a stress pathway, operating directly on health, for example, as manifested in elevated blood pressure, or through health behaviors, which reflect more of the kind of coping responses that one might engage in order to, as part of a reaction to experiences of discrimination. And overall, the association with health is strongest when considering health outcomes that are more mental, psychiatric in nature than physical, although there are many studies showing positive effects of discrimination on physical health outcomes. In terms of understanding the patterns across populations of reports of perceived discrimination, we can characterize it somewhat by differences that are sociodemographic. Not surprising, non-whites report higher levels of perceived discrimination than whites. On balance, reports of perceived discrimination are positively associated with socioeconomic status. The higher socioeconomic status that you have, the more likely you are to report experiences of discrimination. And this may reflect one or more possible processes. One is that there may be higher up in the socioeconomic status in the latter, there may be more opportunities through contact with SES groups and with different racial groups that facilitate more opportunity to be exposed to racial discrimination. Also, at higher levels of SES, there may be different cognitive frames for interpreting experiences, interpersonal experiences, that may make one more likely to recognize or perceive a given dynamic as reflecting bias, or they may be more likely to report in a population health study, for example, that this was an instance or experience of discrimination or bias. Typically, we find that self-reported perceived discrimination is higher among men than among women, with important gender differences in the types of situations. Men are much more likely to experience negative interactions with police, for example, that reflect discrimination or bias compared to women. And although the prevalence estimates vary quite a bit, typically they're often as high as around 80% among blacks in the U.S. Here are results from a review study looking at studies of perceived discrimination reports and health outcomes. So in aggregate, what this review finds is really high prevalence of studies reporting positive associations between reports of perceived discrimination and negative mental health outcomes. Less so among, again, with physical health outcomes, and also pretty high with health behaviors. So health behaviors and negative mental health outcomes are the outcomes where you really see very consistent findings showing the effects of perceived discrimination on health. One important exception to this category of negative physical health outcomes is perinatal outcomes, where you do see pretty high estimates of negative consequences of perceived discrimination on birth-related outcomes. Moving on to measurement. In terms of the measurement options that we're dealing with here, again, some of these axes that we've talked about before, the self-appraisal dimension versus something that would be relatively more objective. We might also be interested in things like we have to take into account reports of events happening, but also recognize there are important differences in the behavioral or cognitive response styles. And these response styles can be a function of individual variation, like related to one's own propensity and negative affect, or propensity for interpreting things negatively or being more optimistic and so forth. But they also are very likely to be socially patterned as a function of social experience. We can characterize discrimination measures in terms of many or very few life domains. And again, this issue about whether it's acute or chronic. And also some measures try to account for the recency of experiences, but also lifetime exposures. And really, as with any of these types of measures, the research question ought to be guiding the choices of the measures used. I want to just elaborate a little bit more on this particular domain, the measures that capture subjective experience or perceptions versus something that could be more objective. Self-appraisal, the term that I've been using and is used in the literature, perceived discrimination, is not an accident, nor is it cynical. It's just an attempt to be as accurate as possible about what is being measured by these instruments, which are one's perceptions of one's social experiences. And the precision is intentional. The interest is usually in actual experiences of discrimination. And what we are usually trying to get at is when people experience discrimination, this is what the impact on health looks like. But we're only able to capture their experiences of discrimination as mediated through their individual perceptions. So the qualifier there on perceived racial discrimination, perceived experiences of discrimination, is really one of precision around the type of measure being used, but often it is the case that what's really of interest is the actual experiences. However, one might also argue that self-appraisal and the subjectivity that is part of that might actually be what's most relevant. If you're thinking about a process and a mechanism for health that's mediated by perception, by interpretation, and by stress, it might mean that discrimination matters most when you perceive it as such. And if you don't perceive it as discrimination, it may not be as impactful, or in certain cases or with certain outcomes, it may not matter as much. And what really matters is whether you do see something as discriminatory or not. So of course the limitations with that is it's really hard to separate perceptions from anything that's quote-unquote objective. And it conflates actual events with one's own interpretations or reactions to those events, and they can't be separated. And of course that introduces confounding by personality variables, some of the individual characteristics that I mentioned just a moment ago. And some studies try to get at that by including personality variables or measures in the studies controlling for things like negative affect. The flip side, of course, is if we could identify and isolate objective experiences of discrimination, we might want to be able to do that, because it's possible that these things do, in fact, matter regardless of our perception of them, and the insidious effects of instances of discrimination really can go unnoticed, and also, but yet still be very important for health outcomes and very impactful on well-being. And the strength of these types of measures, if we could do that well, would be that it would avoid this kind of confounding. But again, the flip side is that we wouldn't really necessarily be able to capture individuals' perceptions, and that may be, in fact, what is the most important dimension of the experience. I'll go through now the three measures mentioned previously of experiences of interpersonal discrimination and just highlight some of the features. In many ways, there are very clear consistencies across the three types. There's an attempt to understand people's perceptions of having been treated unfairly or subjected to bias in a number of different domains. So here with the schedule of racist events, the emphasis here is embedded in the question is because you are black. So the attribution is embedded in the question. Have you been treated unfairly because you are black? And this first example is by teachers or professors, and then trying to capture the temporal dimension of it and recency over the entire life. It also includes this dimension, which is a subjective appraisal of the severity of the experience. So in this instance, with this measure, you have a lot of things kind of packed in one. You have attribution, you have appraisal of the degree of the experience and so forth, but also, like as with other measures, cutting across a number of different domains to try to really increase the content validity of the measure, because if you don't elicit these experiences across a lot of different domains, you might miss important dimensions of experiences of discrimination. Other aspects included in this measure, things like how many times have people misunderstood your intentions and motives because you are black. How many times did you want to tell someone off for being a racist but didn't say anything? How many times have you been forced to take drastic steps to deal with some racist thing that was done to you? How many times have you been called a racist name? How many times have you been made fun of, threatened with harm because you are black? So in all of these instances, the bias dimension and the attribution to race are all embedded within the question stems. In contrast, Williams' measure is a little bit more oblique. What it does is it contrasts major events and everyday. So here again you have the kind of acute life experiences, life stressor stuff, and the everyday hassle stuff, and separated into two different parts of the instrument. The major events. Do you think you've ever been unfairly fired or denied a promotion? For unfair reasons, do you think you have ever not been hired for a job? Do you think you've ever been unfairly stopped, searched, questioned, physically threatened, or abused by the police? Now notice here, the unfairness, the bias dimension, is embedded in the questions, but there's no attribution to race in any of these question stems. Continuing on, these are the everyday hassle dimensions. Being treated with less courtesy than others, receiving less respect, poor service, people acting as if, blah, 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 blah. And you can see these different domains. Again, there's bias implicit in some of this and being treated badly, etc. But even here, there's less attribution to bias than in the previous domain of major events. And there's still no reference to race. And that's because what happens with the Williams items is that individuals are asked to report their experiences with all of these types of events, and then separately they are asked to attribute these experiences to a number of possible characteristics of themselves. So then they're asked to recall any of these items they've endorsed, and then to name the most important reason for receiving this treatment. And that can include things like race, of course, ethnicity, religion, immigration status, gender, even characteristics of physical appearance, age, and so forth. And so they've really separated out here the experiences of some kind of bias, unfair treatment from the attribution to race, and that's why this measure can be used to capture discrimination experiences that go beyond those related to racism. Okay, finally, the third measure is Nancy Krieger's experiences of discrimination. Again, you'll see a lot of similarities here, but in this instance, the attribution piece is embedded, although elaborated a little bit, because it's not just asking because you're black, but it's because of your race, ethnicity, or color. And so this can be asked also of whites and other racial ethnic minorities. So again, several domains in which bad treatment experience, discriminatory treatment, being hassled, or so forth, can be experienced in any of these domains, and also the number of times. Some other dimensions that are incorporated in the measure overall. A universal kind of responses to unfair treatment. If you feel like you've been treated unfairly, do you usually sort of accept it or do something? Is your response typically externalizing it, talking to other people, or internalizing it? This is trying to get a little bit at generalized propensities for responses to look at how the individual's responses might modify the effects of exposures to discrimination on health outcomes. Also, she tries to get at this worry dimension as another way of kind of coming at it from a different direction. When you were a child up to age 18, how much did you worry about people in your racial ethnic group experiencing unfair treatment because of their race, ethnicity, or color? And also, how much did you worry about yourself experiencing because of your race, ethnicity, or color? These questions are also asked with respect to more contemporary time period, not just in childhood. And one final dimension of her measure that I'll mention is these so-called global questions, trying to get at personal versus group perceptions. So here asking about first of all, whether globally you feel that people of your racial ethnic group, or in this case it can be asked of whites, people who are not white are discriminated against, and how often do you feel that you personally have been discriminated against. This is based somewhat on research suggesting that people will be more likely to perceive and report, acknowledge the existence of discrimination against their group as a whole than they are willing to acknowledge and report the experiences they themselves have had personally. And so this is another way of kind of triangulating at people's perceptions of discrimination that may also impact their willingness to report their own experiences, and also may impact the effect of their reported experience on their health outcomes.